You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is May 20th, 2024. Our topic today is Abbas Chapter 21, Congenital Immunodeficiencies, Part 1, presented by Dr. Nikita Raje. She is an Associate Professor of Internal Medicine, Pediatrics, and is the Chief in the Section of Allergy Immunology at Children's Mercy Hospital.
Let's get started. Congenital immunodeficiencies. So this chapter talks about both primary and secondary immunodeficiencies. My goal is to go over primary immunodeficiencies, and I'll let you guys read the acquired immunodeficiencies on your own. If you have questions, let me know. But the congenital or primary immunodeficiencies itself will likely take two lectures. So we'll see how that goes. Okay, so today is May 20th, 2024. I'm Nikita Raje from Children's Mercy, Kansas City, University of Missouri, Kansas City. We'll be talking about Chapter 21 from Abbas, primary and acquired immunodeficiencies. And just as I mentioned, we'll focus on the primary immunodeficiencies for this lecture. Here are my disclosures, nothing relevant to the talk today. So just to recapitulate a little bit about what we learned throughout this book, we learned about innate and adaptive immunity. Remember, innate immunity is hardwired and present and ready to go within minutes of infection, versus adaptive immunity is more sophisticated but takes days to develop. And then for the adaptive immunity to be activated, it still needs input from the innate immune system, where it provides that second signal and tells the adaptive immunity that there is a danger, apart from just that there is a foreign antigen. The adaptive immunity should only be activated when there is a danger signal, which is the second signal. That leads to activation of lymphocytes and their proliferation, differentiation into their effector molecules, and that those effector molecules provide the adaptive immune response. We know adaptive immunity is two different types, humoral and cell-mediated immunity. Remember, really important concept, humoral immunity is plays a role in extracellular microbes, or rather extracellular phase of any microbe, and cell-mediated immunity will act on phagocytosed microbes, where the effector mechanism is through phagocytosis, for example, macrophages, or intracellular microbes by cytotoxic T lymphocytes. Sorry, got distracted here. All right, so apart from that, for the natural killer cells, that's part of the innate immunity. In these natural killer cells target damaged cells. Those cells could be damaged by viruses or cancer, and that would lead to activation of the NK cells through its activating a signal or receptor, and then the inhibitory receptor is inhibited if it's a normal cell. If it's a target cell that is damaged, the inhibitory signal is not available, and that's the reason NK cells go ahead and kill the target cell. Complement system creates this membrane attack complex that will lead to lysis of the microbe. So let's talk about primary immunodeficiencies and their classification. So based on what we just talked about, the classification would be defects in the innate immunity versus defect in adaptive immunity. And you see different subcategories of these immunodeficiencies. Also, wanted to kind of mention this this paper here that goes over the classification of immunodeficiencies given by IUIS, International Union of Immunological Societies. This classification is updated every couple of years. So it's due and will be coming out at the end of the year, this year or maybe early next year. So as you see here, the number of immunodeficiencies have increased exponentially over the last several years. This one is from 2022, where it shows 485 defects. We know that the number has already crossed 500 now, and you see the number of genetic defects that got added since the previous classification that came out in 2019. So the ones in red were added later. So this classification categorizes the immunodeficiencies into 10 different categories: combined immunodeficiencies, combined immunodeficiency syndromes, which means the other systems are involved as well, antibody deficiencies, immune dysregulatory disorders, phagocytic disorders, innate immune defects, autoinflammatory disorders, complement defects, bone marrow failure syndromes, and then the phenocopies of immunodeficiencies. And the phenocopies are typically not genetic. So most of the defects that are primary immunodeficiencies means that the defect itself lies in the immune system, versus secondary immunodeficiency means that the immune system is affected secondarily. Most of the primary immune deficiencies are genetic, but there are some, such as phenocopies, that are not genetic. Either they are somatic variants or acquired autoantibodies that cause similar, they almost copy one of the other category disorder, but they are not due to a genetic defect. Also, some of the immunodeficiencies in other categories are caused by, uh, well, we don't know the genetic cause of those defects or that phenotype. So, but most of the ones that we know are genetic. So more than 500 genetic causes among these categories. So in terms of the genetic causes, I wanted to kind of go over the different types of genetic causes that you would think of, which is, of course, the X-linked, which would be one of the oldest immunodeficiencies that were recognized: X-linked SCID or X-linked X-linked CGD, X-linked A-gamma globulinemia. But we know that some of the immunodeficiencies that we typically talk about, the rare disorders, are autosomal recessive. These are typically caused by defect that is inherited, one variant from maternal side and one variant from paternal side, which is exactly the same variant, which would be called a homozygous autosomal recessive variant, versus sometimes the variant from the maternal side and paternal side are different. So that's called a compound heterozygous autosomal recessive disorder. In terms of autosomal dominant disorders, this can be gain of function variants, where the variant that is present is there's only a single variant, but that causes gain of function, versus there are loss of function variants caused by a single variant. And these could be because there is what we know as haploinsufficiency, which means one of the variant causes a product, so protein product, that is not functional, and the function of the other allele is not enough. So that's called haploinsufficiency. On the other hand, sometimes the loss of function is caused by what we know as dominant negative variants, which means that one variant is abnormal and that variant causes a functional disruption of the other allele as well. So those are all the terms that you really want to know about. Again, for genetic causes, we know that the variants can be inherited, but there is incomplete penetrance, which means not everyone in that with that inherited gene will have the disease. Um, there is variable expressivity, and that means that the gene can be expressed in different ways. So patients in the same family with the same gene defect can present in variable can present with variable manifestations. So thinking about the manifestations, we typically focus on infections, which is our main patient population that we see. Patients with a lot of different types of infections and lots of frequent infections, but also patients can present with malignancies or granulomas, autoimmunity, lymphoproliferation, or atopy. And when you see a combination of these manifestations going on, we should be thinking of immune deficiency workup. An accompanying paper that comes out with each update of IUIS classification is the phenotypical classification. And so that's also something that we'll go over as we talk about the various immunodeficiencies in this chapter. So before we talk about these immunodeficiencies, let's look at the immune response and what we learned throughout this chapter, throughout this book. So say there is a child walking barefoot in the yard and gets a splinter in the foot. The splinter, typically sitting in the yard forever, could have virus, bacteria that could enter the tissue by breaking the first line of defense, which is the physical barrier of skin. So now that it's in there, what's the first set of immune responses that it's going to come across? So there are sentinel cells that it's going to come, that the virus or bacteria that entered is going to come across, which is sentinel cells are macrophages, dendritic cells, and mast cells. Now, when when these cells come across that microbe, they are going to start creating that immune response. So the dendritic cells, for example, will take the message about what kind of infection. Is it fungal or bacterial, viral? Is it in the foot? Is it in the brain? Is it in the liver? It's going to take that information of which kind of infection, where is the infection, and get into the lymphatic system. It's going to take that message to the lymph node through the lymphatics, and in the lymph node, it's going to present that information to the T cells. Now, the B cells also receive that information from other sources, so follicular dendritic cells, complement fragments, and antigen antibody that opsonize that and bring it to the B cells, but that information reaches T and B cells. In that form, all right, so at that time, that message, once it reaches T cells start making effector T cells, so either cytotoxic T cells or T helper subsets, and those T cells come to the site of infection to help in killing the microbes. Also, there are cytokines released from the sentinel cells that enter the blood circulation, and from the blood circulation, they request help, and the first responder neutrophils come to the site of infections to help fight that infection. Complement system also gets activated, as I mentioned. And then the B cells go to the bone marrow and give rise to plasma cells that will release IgM and later switch to G, A, or E, depending on the type of infection. So that's the overall immune response that you would think of in any kind of infection, in any kind of scenario. However, if there is a disturbance of any of these, then there can be an immune defect, right? Immunodeficiency. So thinking about the innate immune defects, we'll start with the discussion about complement defects. So these algorithms are from the IUIS phenotypical classification. I'll let you guys read that paper, but I wanted to kind of have this discussion combining that IUIS classification and Abbas chapter. Overall, the goal of the Abbas chapter is to give you the immunological basis for some of these immunodeficiencies. But then you have to learn way more going into looking at different papers or another textbook or literature or your board review information about each type of immunodeficiency and their clinical manifestations. So we'll do a combination of both, but of course there is much more than what we can cover in these two lectures. So thinking about complement deficiencies, complement deficiencies can lead to infections. And so you think about I'll go to the next slide and come back to this one. It can lead to defects in the early complement pathway. So for each of these pathways, alternative, classical, and lectin pathways that we learned about, the overall goal is to create C3 convertase and C5 convertase. So if there is a defect in the early part of the complement pathway, where before the C5 convertase is formed, it gives rise to early complement defects. Typically, these defects present with sinopulmonary infections and autoimmunity, including lupus, versus late complement defect is after that C5 cleavage and formation of membrane attack complex. So if there is a defect in C5, C5A, C5B, C6, 7, 8, 9, then it can lead to late complement defects that we typically hear about with recurrent infections with encapsulated organisms, such as disseminated Neisseria infections. So the typical testing that we request is the screening test CH50. Typical testing that's suggested or recommended is a combination of CH50 and AH50, and that will tell you which kind of defect you are looking at. And if there is an early complement defect, you will see C3 or C4, C2 deficiencies that can lead to some of the infections or autoimmunity. Also, if there is a defect in late complement defects, so C6, 7, 8, 9, propyridine, factor D, all of these can lead to disseminated Neisseria infections. Apart from that, there are some factors, regulatory factors in complement system. If those are defective, there can be other manifestations such as atypical hemolytic uremic syndrome. So defect in C3 or factor B, factor H, factor I, these are the typical ones where you would think of atypical HUS being one of the manifestations. Factor I deficiency presents with infections. Also, factor H deficiency can present with infections along with the atypical HUS. I'm not going to go into the details of HAE, but of course, C1 esterase inhibitor defect can lead to HAE. All right. We talked about this. Diagnosis is by CH50 and AH50 levels. Ideally, you should be ordering CH50 and AH50 because that's how the algorithm goes of what's normal, what's low, and depending on that, you can narrow down what kind of immunodeficiency you are thinking about. MBL pathway defect, the mannose binding lectin can run low pretty frequently in some people without having an immunodeficiency or without having any manifestations. So it's really controversial if the MBL deficiency really causes a clinical immunodeficiency or not. We tend not to test it. Or if there is a defect in one of these levels, you can consider checking individual complement component levels. Treatment is prophylactic antibiotics or giving extra booster doses of immunizations. All right, give me 1 second here. I'm going to stop here, let you guys, so we are done with complement defects. We'll move on to phagocytic defects. Think about any questions you have about complement defects. I'll be back in a minute. All right, any questions?
A quick question. When do we check? So if CH50 is abnormal, that's when we check AH50. But obviously, if our CH50 is normal, our H50 would be normal.
So ideally, your clinical evaluation or lab evaluations should include both CH50 AH50 at the same time, because that's how the algorithms are described. However, AH50 for our institution is it's an send out test, it's expensive, so we tend not to send AH50 every time. Now, if you are suspecting a defect, such as in, say, patient presents with Neisseria infections and your suspicion for alternative pathway defects is high, in those cases, you do have to check AH50. But otherwise, if there is a patient with sinopulmonary infections and you are thinking more about it, defects in the classical pathway, you could start with CH50. Ideally, it should be both, but we don't typically practice in ideal situations, right? So, okay. All right, let's move on. Start with phagocytic disorders. So phagocytic disorders, the genetic causes of phagocytic disorders include congenital, or sorry, not congenital, but genetic causes of neutropenias. So the most common forms of neutropenias is secondary to chemotherapy or benign congenital neutropenia that does not have a genetic defect. But here we are talking about neutropenias that are immunodeficiencies, which means they are genetic in origin. Severe congenital neutropenia means that the neutrophil count, absolute neutrophil count, is less than 500, and that's caused by several genetic defects mentioned here, Elaine and HAX1 being some of the more studied ones. Cyclic neutropenia is another one, where these patients typically present with recurrent fevers and a neutropenia that comes in once every, typically in a cycle, so maybe once every month, once every 3 to 4 weeks, where the neutrophil count will drop and they'll have fevers, and then the neutrophil count in between those cycles will be normal. Shwachman-Diamond syndrome is another form of congenital neutropenia as well. The other defects here are mentioned where there are phagocytic disorders. Let's look at some of the a couple of the common ones, which are leukocyte adhesion defect and chronic granulomatous disease. You can actually test for myeloperoxidase deficiency if there is a if you think it's a phagocytic disorders and you don't have an answer from other testing. Specific granule deficiencies have been described. We'll talk about Shirdia-Higashi in another. Even though it has a phagocytic disorder, it has other defects as well, and so it's classified in a different place. Same with hyper-IgE syndrome. There is a phagocytic defect, but it's better described as a combined immunodeficiency syndrome. So here is the classification for phagocytic disorders, whether it's a syndrome or not a syndrome. So thinking about that, we talked about some of these Shwachman-Diamond, some of the neutropenias, but again, this is a long list of phagocytic disorders described here. Let's talk about, let me see where are, all right, so 2 tables, right? So these are the neutropenic disorders that are either syndrome associated or non-syndrome associated, so all quantitative defects, and then these are more the functional defects. And again, the most important ones being leukocyte adhesion defect or chronic granulomatous disease. But look at that, G6PD deficiency is one of the disorder that can present in the form of neutrophilic disorder with infections. And so something to consider is G6PD level that you can check on. All right, so let's talk about these phagocytic disorders. Let's talk about leukocyte adhesion defect. So think about these neutrophils. These are first responders. They are always on call 24/7, and they can be called anytime to go to the site of infection and help. right? So just like you guys are on call, these neutrophils are on call all the time. And so think about, you are on call, you are going home, and you are called in, you are paged and asked to go back to the hospital. You're going to have, if you are driving on a freeway and you're in the fast lane, you move to this peripheral or slower lane, apply your brakes and move on, take an exit and go back to where you are needed. And so same thing happens with these neutrophils. Think of them as being on call, right? So they are flowing through the fast lane of the circulation, which is the center lane of that circulation. And when they are flowing through, if they are asked if the site of infections releases cytokines that reach the circulation saying that they need help, these neutrophils have to move from that fast lane to the peripheral lane and close to the vessel wall. That's where they apply their brakes. So that's where they use their adhesion molecules, which help them roll on the surface and then come to a complete stop. And once they come to a complete stop, they can take an exit from the blood vessel and go to the site of infection. If there is a defect in those adhesion molecules, which means that they cannot apply the brakes, they are trapped in the circulation. They cannot come out of the circulation because they don't have the adhesion molecules or the brakes that help them come out of the circulation. So the defect causes leukocyte adhesion defect, typically described as a defect in CD18, but we'll see how there are different types of LAD. So thinking about the basis, the immunological basis of this defect, remember we talked in chapter 3, there are selectins and integrins, right? Selectins help these neutrophils to roll on the surface of the blood vessel wall. That requires Sial-Lewis X, versus the integrins are such as CD18 with CD11A, CD11B, CD11C, and those combination of integrin alpha and beta chain together form LFA1, MAC1, or P15095, which is CR4, complement receptor 4. MAC1 is complement receptor 3. If there is a defect in any of these, then there is an integrin defect. And then once they come to a complete stop, so rolling on the surface and then integrin attachment to their ICAMs can bring them to a complete stop. Once they come to a complete stop, they can use diapedeses and move out of the circulation. They follow the trail of chemokines to the site of infection. All right, so if there is a defect in integrins, the beta chain of the integrin CD18, then it causes LAD type 1. That's the most serious form of LAD, presents early in life, causes delayed separation of umbilical cord, no pus formation, and there is no pus formation when these patients present with skin and subcutaneous infections. That means that these patients will have infection in those areas, but if you try to drain it, there's no pus coming out because pus formation needs these neutrophils to come out of the circulation, go to the site of infection, and kill the microbes and kill themselves. That forms the pus. Because these neutrophils are trapped in circulation, there is no pus formation. But the site of infection continues to send signal to the bone marrow saying that they need help. And so they need more neutrophils. So the bone marrow continues to make more neutrophils. So the neutrophil counts go up in circulation. However, they are not helpful because they are trapped in circulation. LAD type 2 defect is in Sial-Lewis X. Defect typically is because of this fucose transporter that transport fucose into the Golgi apparatus, helping the production of Sial-Lewis X. Because there is no Sial-Lewis X produced, these patients can present with LAD. So this is a selectin defect. These patients will have developmental and growth retardation. They also have something called Bombay blood group. What does that mean? Bombay blood group means that the blood group A, B, or O all of them have a core antigen called H. Because that H antigen needs fucosylation, which is defective in these patients, there is no blood group A, B, or that blood group antigen H. So they have a very rare form of blood group called Bombay blood group. Now remember, LAD type 2 is also a congenital disorder of glycosylation. So this GDP glucose transporter is defective. So these patients will have non-immune manifestations, as I mentioned. And then LAD type 3 is defect in that inside out signaling. So remember that low affinity integrin binding, when there is an inside out signaling because of chemokine binding to chemokine receptor, that low affinity integrin turns into high affinity integrin. So the chemokine receptor is so the receptor binds to its chemokine ligand, and because of which the signaling that is inside the cell leads to the end result that is outside the cell, which is improving the affinity of integrins. So it's called inside out signaling. Defect is in kindlin 3. Kindlin 3 is a molecule, so the gene encoding kindlin 3, if it's defective, it leads to LAD type 3. These patients present a little later in life. They have infections, but then bigger issue is bleeding issue because of platelet aggregation defect. The number of platelets is normal. Typically in LAD, infections are caused due to poor wound healing. They have skin and subcutaneous infections, periodontitis that they can present with. Treatment, again, here is antibiotics, supportive therapy. If it's LAD type 1, which is the most severe form, these patients need stem cell transplant for survival. Next one is chronic granulomatous disease. Yeah.
Hey, Dr. Raje, can I ask a quick question?
Mm-hmm.
So, there's been maybe 1 or 2 times where I've gotten a page about a patient that has like delayed umbilical cord separation.
Mm-hmm.
So whether it's like a premature baby, they've been in the NI or whatever it is, it's greater than 21 days, and so they're concerned about LAD. Say hypothetically they have that, but then also their CBC with DIF doesn't show significant leukocytosis, and they're otherwise, like, I would say, healthy for a child, like a baby. At what threshold do you go ahead and pursue like the CD18 testing and all that stuff? Because I think, most babies have umbilical cords that fall out within that 7 to 10 day range, right? But I've also seen that, like, and I was talking about it with my daughter's pediatrician, that they frequently see above 3 weeks. So at what point are we supposed to be pursuing this more specialized testing in what appears to be an otherwise normal child?
Right. And so, typically I don't see these patients if they are coming, if their umbilical cord is separated within those 20-25 days. The pediatricians know that that's like in that normal bell curve, right? Like there is some variation, but it's still normal. They don't have any other infections going on, they don't have any other manifestations, and typically we don't even hear about them. The ones that do present typically will be because of so I recently saw a patient because uncle or someone else had LAD and they had delayed separation of umbilical cord, and then this patient presents with delayed separation of umbilical cord, for example. So again, so family history is important, infections like that history is important, and then as you noted, just getting a CBC and seeing if the neutrophil count is normal or high, and typically you will see a high neutrophil count if it is LAD. So again, so I think it just depends on the overall presentation. So I don't think there is like a clear cut demarcation of 21 days you don't do it and 22 days you do it, and I don't think I personally know of such a cutoff, but typically it's the overall picture and the neutrophil count and all that goes together.
Okay, so like a normal CBC without significant leukocytosis and all that stuff is overall reassuring to give it extra time, right?
Yeah, it is. It
You would
is.
say?
Unless, again, see if there is a family history or something that kind of strikes out as odd, I would go ahead and do testing. I would go ahead. It's a easy flow cytometric test to get the markers for CD18, CD15A, which is for the type 2 LAD, and so those are easy to get. So if there is increased suspicion, I would just go ahead and get that. Okay. All right, moving on to CGD. This is a defect caused by defect in the genes encoding this enzyme complex called phagocyte oxidase, or FOX, that is present in phagolysosome, or it's also called NADPH oxidase complex. It has various components of it, as you note here, the names written up here, and the most common form is the X-linked, which is caused by GP91 defect, versus the others are autosomal recessive. What's the immunological basis here? In general, neutrophils form phagolysosomes. So once the bacteria or fungus or whatever is ingested or phagocytosed, it binds to a lysosome to form phagolysosome, which has this enzyme complex that gives rise to reactive oxygen species. Reactive oxygen species is acted on by superoxide dismutase to form, am I saying it right, hydrogen peroxide, and then myeloperoxidase converts it to bleach. Right, so hydrogen peroxide here, bleach here. Hopefully you guys can see my pointer. If not, let me know. And so these chemicals, reactive oxygen species, hydrogen peroxide, bleach, all of them are used in killing of the microbes. Apart from that, there is this proton channel that is activated because of that electron transfer from NADPH to, and that is also important for the bactericidal or microbicidal action of these neutrophils. The third type of mechanism that these neutrophils use in killing microbes, if you recollect from the chapter that we talked about, is creating nets or neutrophil extracellular traps. So it extrudes its DNA and the chemicals onto the microbe, and then kills that microbe that way. So what happens with CGD if there is a defect in this enzyme complex? It causes infections by catalase positive organisms: Staphylococcus aureus, Burkholderia cepacia, Nocardia, Serratia, Aspergillus, other fungus such as Candida. All of those are typically found with CGD. There are some microbe fungal infections. If you notice them, it's almost pathognomonic of CGD, and you should be testing them for CGD. Why is it catalase positive organisms? So when there is a defect in this complex, it cannot give rise to hydrogen peroxide. However, the microbes themselves will, their own system, their own oxidase, if the defect is in the human cells with the oxidase complex, the bacteria themselves have a mechanism to give rise to hydrogen peroxide. So if it's a catalase negative organism, the neutrophils can use their hydrogen peroxide to kill the microbe themselves, so using their own system against them. But if it's a catalase positive organism, the catalase enzyme will break down that hydrogen peroxide that is coming from that microbe. So host or the human cells cannot use that hydrogen peroxide to kill those microbes. And so because of that, the catalase positive organisms are able to cause infection in these patients. So because the neutrophils cannot control that infection, it will lead to attraction of other immune cells to that site. So it brings in macrophages and other immune cells to give rise to a formation of granuloma. Diagnosis of this immunodeficiency is done by dihydrorhodamine assay or oxidative burst test. The previous test was nitroblue-tetrazolium test that's not used anymore. Treatment is by antimicrobial prophylaxis. It's called triple prophylaxis, which is antibacterial, antifungal prophylaxis, as well as interferon gamma. In a small study, it has shown to increase the NADPH oxidase capacity of these neutrophils. All of this is supportive therapy. So the curative therapy is stem cell transplant. There is gene therapy available on research basis. However, there are patients who have stem cell transplant. Stem cell transplant should be considered in patients, highly considered in these patients when they have absence of. Sorry, give me 1 second. So the stem cell transplant should be considered in patients who have absence of oxidative capacity, and that can be noted on the dihydrorhodamine test with their stimulation index. All right, so here's the dihydrorhodamine or oxidative burst test, which shows a normal person whose neutrophils are stimulated with PMA and they show fluorescence. So what is this assay? Dihydrorhodamine used to tag the neutrophils that are taken from the blood sample, and they are stimulated. When they are stimulated, the dihydrorhodamine is oxidized to rhodamine, and rhodamine is fluorescent, so it can be the mean fluorescence intensity is noted on these histograms. So there is shift of that histogram, as you note in the upper panel here. So this is a normal person with normal oxidative capacity. If the oxidative capacity is absent, as in X-linked CGD, for example, the dihydrorhodamine is not oxidized to rhodamine, because of which there is no shifting of that graph. These are different types of DHRs that are noted here. Some of the autosomal recessive forms will show a graph that has shifting of the graph a little bit more than the X-linked CGD, but not to the normal level. And you compare that to the control. All right, so there is a good paper to look at the stimulation index and the MFI, so mean fluorescence intensity, to decide if there is complete absence of oxidative capacity, or there is some oxidative capacity that would help us kind of determine if the patient has any neutrophils with some oxidative capacity. Moving on from neutrophilic disorders to defects in innate immune, so there are categories, these are the categories of IUIS classification: complement defects, oxidative capacity, and then the defects in intrinsic or innate immunity. That leads to, again, these are two algorithms here. The first one is predisposition to viral infection. The other one, predisposition to bacterial, fungal, and parasitic infections. So as you go through this, you'll notice several different subcategories of innate immune defects. One such category is predisposition to herpes simplex encephalitis. That's a defect in TLR3 pathway. You notice several other defects here. Predisposition to HPV is another one, where these patients can present with warts, like WIM syndrome. That is a defect in CXCR4. There is EVER1 and EVER2 defects, where there are no other issues, but mainly just these HPV infections and increasing the susceptibility to cancer. SIB1 is another one. Other ones that you note here are defects in type 1 interferons. Interferon are receptors such as interferon receptor 1 and 2 defects, or IRF defects. IRF7, IRF9 defects can lead to increased susceptibility to flu disease. Similarly, the defects in STAT1 gain of function or loss of function can lead to what we know as Mendelian susceptibility to mycobacterial disease. These patients can have candidal infections as well as the candidal infections is gain of function STAT1, so that's not the loss of function though. So MSMD, or Mendelian susceptibility to mycobacterial disease, will present with salmonella infections and mycobacterial infections. In the same pathway, if the defect is more downstream, there can be infections from other viruses as well. All right, moving on, we talk about some of the NK cell defects in a little bit, but I just wanted to show you all of those. Here are the defects in TLR pathway, other than the TLR3 pathway, TLR3, which leads to infections with pyogenic bacteria, such as IRAC4 and MyD88. That's the one I was talking about, the STAT1 gain of function that leads to frequent candidal infections. This is a category where there is predisposition to chronic mucocutaneous candidiasis. So CMCC is what it's called. That again, these are some of the defects here: IL-17 pathway, STAT1 gain of function that lead to, or JNK1 haploinsufficiency, all of them causing CMCC. CARD9 is the only known defect that leads to predisposition to invasive fungal infections. So that's something to keep in mind. We talked about Mendelian susceptibility again, that comes up here. There's this long list of MSMD, so interferon gamma, R1, R2, STAT1 loss of function, IL-12 defects, IL-12 receptor defects, or interferon gamma receptor defects. And so you can actually give interferon gamma to the patients who have IL-12 defects. However, if it's the receptor defect, you cannot really, the interferon gamma doesn't do anything for those patients. Right, so here is another one called TIC2. Defect in that leads to MSMD along with mycobacteria and salmonella. It can also cause viral infections. Macrophage defects can again lead to infections in the similar category. Here, again, IRF8 is one that can cause infections from various other microbes, not just the mycobacteria. All right, those are the ones I wanted to point out. NK cell defects, again, this is still part of the innate immune system. NK cell defects can be quantitative or qualitative. GATA2 deficiency will present with low NK cell numbers. Along with that, the monocytes and dendritic cells are low, B cells are low. These patients present with severe viral infections, so HPV or HSV. It can present with mycobacterial infections. It will also have other manifestations like hearing loss and lymphedema. Pulmonary alveolar proteinosis is another one, and these patients are susceptible to develop cancers. MCM4 and Fc gamma R3 are functional NK cell defects. MCM4 MCM4 is actually a quantitative defect along with low NK cells. It will also present with adrenal insufficiency and growth retardation. And Fc gamma R3 or CD16 is defect in NK cell function. So the antibody-dependent cytotoxicity is defective, and these patients present with HPV and HSV infections. This basically goes over the TLR function. Remember, TLRs make a dimer. Once they form that dimer, there is signaling that goes through either the IRF pathway or the NF-kappa B pathway. The signaling molecules or adaptive molecules in between are mediated IRAK4 versus on the side of TLR3 pathway, it's TRIF and TRAF, followed by IRFs being activated. The TLR pathway will lead to NF-kappa B or AP1 transcription factors to be activated that go to the nucleus and lead to the transcription of various inflammatory genes. In the case of IRF3 and IRF7, it will lead to transcription of interferon, type 1 interferons for antiviral defense. But if there is a defect on either of these sides, there can be a problem with the defense against some of these microbes. So mediated IRAK4 will give rise to severe invasive bacterial infections really early in life. Later in life, these infections can actually get better. Remember, these are the patients who will have severe infection and may not present with fevers, and they may not have elevation of acute phase reactants like CRP. Despite having, say, mastoiditis or sepsis, they will not have elevation in CRP, they may not have fevers. We talked about TLR3 pathway defects where presenting with HSE, TLR3, TRIF, TRAF3, TBK1, IRF3, UNC93B, STAT1, all of these are in this pathway, right? So UNC93B is important because it's not in the pathway, but it's important for localization of the endosomal TLRs where they are supposed to be. So defect in that also causes HSV encephalitis. Defect in the NF-kappa B pathway. So remember, we had talked about NF-kappa B pathway. There is a canonical pathway and a non-canonical pathway. It's downstream of various receptors, so not just TLRs. It's also downstream of TCR, so T cell receptors, B cell receptors. It's downstream of TNF receptors. So any of these bind to their ligands, it will activate this pathway where the NF-kappa B that's bound to its inhibitor has to be released. So there is an IKK complex, so the kinase complex inhibitor of kappa B kinase has three components: alpha, beta, and gamma. And defect in any of these components can lead to NF-kappa B pathway defects. Their NEMO defect is X-linked. And so NEMO stands for nuclear factor kappa B essential modulator. And so it's a modulator because it's a regulatory part of this complex of alpha, beta, and gamma. What happens with when this is defective? There is anhydrotic ectodermal dysplasia. So conical teeth, sparse hair, nails are defective, all of that together. So these patients will have, apart from that ectodermal dysplasia, will have severe infections with pyogenic bacteria, bacterial infections, mycobacterial infections, fungal viral infections. So these patients can be present with pretty significant infections. Similarly, I kappa B alpha, so this is the inhibitor of kappa B. If that has a defect, it can also present with ectodermal dysplasia. So EDAID means ectodermal dysplasia associated with immunodeficiency. So that's a typical presentation that you might hear about. That's just showing the ectodermal dysplasia. Defect in IL-12 and interferon gamma pathway, that's your MSMD. These patients can have defect in either the IL-12 cytokine, IL-12 receptor, interferon gamma receptor chains, STAT1, NEMO, ISG15. These are some of the common ones that you will hear about, but we looked at the table. It has way more number of defects. defect in any of these, remember this is the pathway for intracellular microbial or Th1 pathway. So Th1 pathway defects will lead to mycobacterial disease and salmonella infections, and some of the other ones can present with viral and other infections as well. There is a congenital asplenia gene defect called NBX 2.5, and that encodes for transcriptional regulation of splenic development. Because of the defect in that, it can lead to isolated congenital asplenia, and these patients are at risk for having severe infections with encapsulated bacteria. So that's what we wanted to talk about for innate immune defects. I believe